is so fast that this can lead to a long-term disability. And once the joint or the bone is destroyed, then it is very difficult to treat, and it may end up in a disability for a long time to come. Now, what is, and therefore, it is important to, understand and always have a high suspicion. What does it mean? To infection, bone is a group of condition in which there is presence of bacteria and an inflammatory response. Because of the inflammatory response, so many enzymes are secreted, and those proteolytic enzymes can cause a damage to the bone itself. And then, or it can also be defined as a suppurative process in the bone caused by a pyogenic organism. Now, what it shows is that do not hide your head into the sand. When you see a case like this, suspicion, diagnosis, and then the treatment in these cases should be started at an early stage as such. But before we start, we must take a diagnostic specimen in all cases. Now, just as you know that, when there is a infection within the tonsil, that is known as tonsillitis, appendicitis. When there is infection in the bone and the bone marrow is known as osteomyelitis. The word osteo means bone. And if there is a degenerative condition of the bone and joints known as osteoarthritis. The word arthro means the joint itself. The word osteo means the bone. And when there is softening of the bone itself, softening of the bone because of deficiency of vitamin D, that is known as rickets in a child, and in a grown-up is known as osteomalacia. Malacia means softening. Now, the commonest type of this is acute hematogenous osteomyelitis, when there is a bacteria from the blood bone, and from the blood it settles down into the bone. Now, just so you know that the bone, because osteomyelitis is most common in small children. So in small children, the bone has got a main bone which is known as the shaft of the bone. The shaft is known as a diaphysis, and the top end of the bone is known as, in children, epiphysis. And then the area from the epiphysis to the diaphysis, the joining area, is known as metaphysis. The circulation in the metaphysis is not only rich, but because there are end arteries, the circulation there is not at a very fast rate. Therefore, the bacteria have time there to slow down. And therefore, they have greater time, they slow down. And therefore, the metaphyseal area is more prone to infection. And that, now, out of the various osteomyelitis types, hematogenous osteomyelitis is the most common. The risk factors are that if has got diabetes or chronic kidney disease, rheumatoid arthritis, immunopathies, or the host is immunocompromised, then the risk is high. But even a healthy kid, because that just means that if the ability of the patient is down and he cannot fight the infection in a better way, then pathogens are, so this, just as we said, that this can be of three different types. One is known as acute hematogenous type, which is the most common. One is contiguous focus of infection. So that if there is a skin damage or there is a chronic deficiency, then from the skin, the infection can go into the bone directly. Other is direct inoculation. So that if you have got a direct injury to the skin, and then from the skin, the infection can travel to the bone itself. It's known as direct. But the commonest way of developing bone infection in children is hematogenous. Therefore, it's known as acute hematogenous osteomyelitis. Now, it is very important to understand that once the bacteria has gone in, then what happens? Then, when the bacteria has gone in and it has gone into the bone marrow or into the area, it causes the cell death. And when there is cell death, because the bacteria will release the toxins, though, and that becomes then there is a cell death, and the death cells itself can become a culture medium, and because of the inflammatory reaction within that, there will be the vascularity will go up, and there will be a leukocytosis. And when the vascularity has gone up, there are more vessels. Now you have to understand that the bone is a compact structure. So when in the medullary cavity, the vascularity goes high, it becomes swollen, then the pressure within that rigid osseous container will go high though. And when the pressure in the bone goes high, that will cause the pain. And as a reaction to that though, the skin and the surrounding tissues can become though dead. And now in certain areas like the hip joint and some other joints though, the metaphyseal area, the joint capsule, the capsule of the joint, like the capsule of the hip joint and certain other joints, comes up to the metaphyseal area. So when there is a pus there, and if the pus will burst, if it bursts into the capsular area, that one is intercapsular, it can enter into the joint itself. So in some joints, the metaphysis, where the part of the metaphysis is intercapsular, it can enter into the joint and cause septic arthritis. Now, why is the bone infection more common in the metaphyseal areas? Because in the metaphyseal capillaries, as the capillaries goes up, there's a sharp twist. And because of sharp twist, the flow in the capillaries and the veins becomes, the flow is not only decreased, but the flow becomes, stagnant. And therefore the bacteria in that area can stay for a longer time. And then many of these arteries here are the end arteries. And then the two precipitating factors are, there can be a combination of trauma and the bacteria. Now, this is a diagram which, although it is a big diagram, but it is important to see that what is happening here though. Just so you know that the shaft of the bone is known as diaphysis. And then here, which is where the bone is coming to an end and is growing up, known as metaphysis. And the top end, which is the growth cartilage, that is known as the epiphysis. And then the growth itself, because just you know that this growth plate in children lasts up to the age of 14, 15, 16, till the epiphysis and the metaphysis, so that growth plate is here. So there's epiphysis, and then there's a growth plate here, and then this area of the bone is known as metaphysis. And then the capillaries here, the bone here, they are here in end. So, and then within this area, there's a high cell turnover. There's a relative lack of the white cells or the phagocytosis. Here is a bit less, and then there are all these cartilage cells. And most of these, arteries here are end arteries, and this area is, in children. So you know that within the whole body, the areas which are more common to acute osteomyelitis are the femur and also the lower end of the tibia though. And the children who just idhar bhag rahe hain, wahan bhag rahe hain, ye sab ho raha hai, so they are more prone to trauma. And naturally the trauma is more prone in those areas though. And those are the areas which are more prone, not only more prone to trauma, but more prone to develop the bone infection in those areas. And this is a whole diagram that we have to know what is happening. Okay. So just as you know, just as we discussed that this part of the bone, the shaft of the bone is known as the diaphysis. Where it comes here, in this area, where it widens up is known as the metaphysis. And this line which you see is the growth plate. Growth plate in children is also known as physis. And this is the articular cartilage, and this is known as the epiphysis. So this is the area. So this is the most important area. Within the last thing we just discussed, that in the metaphyseal area, there are end arteries, the capillaries have been twisted, hair bent, and the circulation in that is not very fast, and therefore the bacteria have got more time to stay because of stasis, stagnation, lack of phagocytosis, and the area is more prone to trauma. If the bacteria can stay a bit longer, and especially if the host is immunocompromised, there's more chances of developing infection in that area. The transient. So if there's a bacteria here, now just so you know that there are so many bacteria, but the commonest kind is a Staphylococcus aureus. The second commonest kind is then you can also have a infection with the gram-negative bacilli, and and now, so when there is here, just as we discussed that there will be a breakdown, and then there will be just necrosis, and this will cause this bone pain, and also it will develop an abscess. So when there is an abscess or inflammatory reactions, and it is a bone is a compact, I mean compact and a rigid structure as such. So when there is compression of this bone, this will cause severe bone pain, a severe bone pain. And if through this bone, because the bone is soft, it will just rupture. When the pus of this ruptures here, then just as you know that in children, there's a very thick covering. The bone is always covered by the lining or by the covering layer that is known as periosteum. The cartilage is always covered by the layer known as perichondrium. But this bone, this layer, although is very thin in a grown-up people, but in children, because the periosteum is very thick, but new bone develops there as well. And then when it will rupture through the bone, it can form what is known as a subperiosteal abscess. Subperiosteal abscess. And naturally, when there's an abscess in the bone, rupturing here, causing a subperiosteal abscess, it will cause an inflammatory reaction within the surrounding soft tissues as well. And therefore, when the child comes, that area will be swollen, and the skin and of the area may also be red. So there will be a red and a swollen skin. And if the key here is, this is the joint capsule. This is the joint capsule. Now, in some joints like hip joint, ankle joint, what is happening? That the joint capsule is here at the metaphyseal area. Therefore, if there is a rupture, this can rupture into the joint itself though. If the abscess or the pus ruptures into the joint, this can lead to what is known as septic arthritis. Other important thing is that this will lead to the if this pressure goes on, therefore you see the important thing to all learn here is that we must diagnose them early. And number two is treat them adequately. A late diagnosis or an inadequate treatment can lead to a morbidity for a long time to come. This is a this can call local bone necrosis. If there's a local bone necrosis, then it can develop a dead piece, and then there's pus, and there is an interosseous abscess. The sequestrum is a very important, because sequestrum means a dead piece of bone. That is very important because when there's a dead piece of bone, it harbors the bacteria, and it's very difficult for the antibiotics to reach there, and therefore the infection becomes then difficult to treat. So diagnosis and treatment at an early stage becomes important. So adequate diagnosis and early diagnosis and adequate treatment are two very important things. Now, osteomyelitis is common in the first decade. Is more common within the boys, and the recent in the last 100 years or so, the mortality rate has gone from 50% now down to less than 1%. But naturally, with this, our use of antibiotics, which we don't give for a full dose, and the most appropriate way, what has happened? We have created more resistant organisms, and therefore the treatment in some cases becomes complex. It becomes a bit complex. Now, this is just to show that which areas of osteomyelitis are, which are common in. So it can happen just, in all over though. Every bone, we've got 206 bones, all bones can have them, but it is very rare here. Skull, it is only 1%. Maxilla can have neonatal maxilla. But just you can see that from all this area, the most common is, tibia is about 19 to 22, and the femur is 23 to 29%. And in femur, especially in the proximal femur, it is very important. Why? Because we discussed that if it's a proximal femur, if we have got infection here, then because the capsule comes up here, there's a great chance of this going into the hip joint. And just as you know, that the articular cartilage in children, if there is an infection, it can be destroyed at a very, very rapid rate though. And once this growing cartilage has been destroyed, and there's no cell, you cannot bring the dead cartilage or the dead joint back again. Therefore, it is very important. A high index of suspicion and early diagnosis of proper treatment is very important. Now, when the child or something comes to you, what does he have? I mean, he has got bone pain. He will have pain. But remember, this infection can occur within the neonate as well, in the child as well, or a 4-year or a 10-year. So naturally, if there is a child who cannot talk, then he will be just, crying. But if a child who can just show you, okay, I've got the pain here, or he will show you that he will have bone pain, he will have fever, child will be ill. This is a serious infection. Child will be ill, he will be generally discomfort, feeling uneasy and ill, and the localized area of that arm or that leg will be swollen and red and warm, and because of this endotoxins or exotoxins of this bacteria, this can have chills, it can have the heart. If there is a low back pain can be, because just as we know that osteomyelitis can affect all bones. So if it is in the vertebra itself, it can cause low back pain. Similarly, it depends if it is ankle, feet, or leg. But if it is a child who cannot say anything, it will be just a irritable crying child. And you can see his arm, he's holding it in this way because he can't move. And what is this known as? It's paralyzed. But he's keeping in this way because he can't move because of pain. This is known as pseudo-paralysis. So when you see these children, you have to take the history there. Whereabout is the pain? How long have the symptoms has been for? How long has it been not very well? Changes in behavior, present trauma. Has there been any trauma? And you have to see vital signs. Just as we discussed last time, if you see a fractured femur, shaft of the femur, which is a very strong bone, you have to see, is the patient alive? Similarly here, you have to see if the child has a severe infection, you have to check his vital signs as well. Is he all right? What is the resting position of that limb though? And how much is the active and the passive movement there? These are important things though, because especially when we are dealing with a child who has come with a suspected hip. So suspected septic hip within a child, you have to be very careful. And the active and the passive movements of that is very important. So we'll come to that. But that is a topic number 2, which is known as septic arthritis. So localized tenderness, limp or refusal. Now, basically, you know that your professor Karam has been very kind, but today we have started a bit delayed though. But he has been so very kind and helpful. Now, when you have got this suspicion, you have to then watch it. Now, the tests are the CRP. As you know, CRP is a C-reactive protein. We used to rely on the ESR, but now rely on the CRP. And CRP is up in 98% of the cases within 6 hours. It goes up quickly and it comes down quickly. And the monitoring, because you have to monitor when you treat these children and you give them appropriate antibiotics, then you have to monitor that is the CRP going down. And CRP is the most sensitive monitor of the treatment. And within 5 to 6 days, once the infection is all gone, it will come back to normal. And the ESR is up in 90% of the cases. This normally peaks in 3 to 5 days. CRP will go up within 6 hours. But this blood cultures, very important to take the blood cultures in a febrile septic time. They are positive, but they're only positive in osteomyelitis in only 30% of cases. Raised white cell count can be seen in about 25. And the plain X-rays can be helpful, but are not very helpful. And MRI, and then the scan, not a CT scan, but a bone scan. We'll just come to that. So all these tests. So if now the plain X-rays, although they are always done, because you You don't know that this is 1 day old or 2 days old, 10 days old. But the plain X-rays in the early stages may not show a lot. It may show just a rarefaction of the bone and may show some swelling and some loss of the tissue planes, but will not show a dissection of bone, because the dissection will appear in the bone after about 10 to 14 days. But the first 7 to 10 days, what you see is rarefaction. There's a decreased density, and there's loss of tissue planes, and there's a swelling of the soft tissues, etc. If you just see here, you'll just see it. What's happening here? Soft tissues have been sewed in. You can see sewed in, and you can see some rarefaction of the bone here. Then you come down here, you see there's some rarefaction, loss of density, rarefaction of the bone, and thread. So those are the early stages. But if you assess but before the changes in the bone, you can see the changes if you do an MRI scan. MRI scan, and you can see these changes here. See these changes here and the changes here. This is the pus. Then this is a bone scan, a technetium 99 scan, in which you just, this is a radio isotope scan, and the scan is done in 3 phases. As a final year, you will have to know about this bone scan. I mean, we don't have time, but one day we can just talk, because a bone scan, you have to know that when it is done, whether there's a vascular phase, the delayed phase, because it's very important to know what is the vascular phase and what is the delayed phase. But in a delayed phase, in osteomyelitis, we have to always see the delayed phase, means this is done 3 hours after the injection has been given. Vascular phase is the scan done within the few minutes after the dye has been given. Then you go ask them to just wait, and then one scan is done, second, and the third is done about 3 hours later. And 3 hours later, then here you see there's high uptake within the bone. And then this, like here you can see, this is a delayed phase. This is a lateral view of the ankle and the lower tibia. And as we discussed, about 25% of the case of acute hematogenous osteomyelitis occur here, though. So here, because this is a metaphyseal area. This is the diaphysis, metaphysis, and then lower joint. It is the ankle joint there. And these are the areas in children, the toddlers, they just begin to fall down. So because of that, I mean, this area is more prone to trauma. Now, once you've made the diagnosis and then how will you treat it? So just as we know, first of all, we have to know that the plain X-ray only shows deep tissue swelling and loss of the tissue planes, but will not show any destruction of the bone at such an early stage. Because this plain X-ray only show deep, means we're talking about early stages. If the child has come in the first few days, 1, 2, 3, 4 days, even up to 7 to 10 days, you will not see a great destruction of the bone itself. वैसे तो ये है कि भाई टाइम जरा कम था, तो इसलिए मतलब यानी हम लोगों ने थोड़ा देर से स्टार्ट किया, वरना स्टार्ट करने से पहले आदमी पूछता है कि आप सब लोग ठीक हैं, you're all well, कोरोना के वहाँ हालात ठीक हैं, कंट्री ठीक है, क्योंकि आई कैन सी करम अली शाह साहब ने वो मास्क पहना हुआ है, तो आप सब लोग अपना मास्क पहन रहे हैं, अपना ख्याल व्याल ये कर रहे हैं अभी, तो भाई ये है कि हम सब की दुआएं, आई मीन यू ऑल आर इन आवर थॉट्स. यहाँ भी हालात अब कुछ ठीक हो रहे हैं आस्ते आस्ते. Then there is this, I mean, technetium scan. Technetium 99 scan, this has got an overall accuracy of 92%. In some cases, this may be cold even. Hot scan ka matlab, hot scan, what is hot scan means? There's more vascularity. But sometimes there can be a cold scan. Cold scan can be if the infection is so aggressive and there's so much abscess. That is not so much abscess within the bone that is compressing the blood vessels and does not allow the dye to go in. So in some cases, even a cold abscess can be a sign of more aggressive infection. But however, just so you know that this, I mean, the MRI scan is 88 to 100%. So this is the most sensitive test. But naturally, the MRI scan is not available at all the time. So we have to rely on our clinical diagnosis, the clinical features, and then temperature, and then the area, and then the pain, and of course, then just as we discussed that he will have a white cell count high, and then we have to diagnose upon his CRP. So it's the clinical features and his history, clinical examination, and important laboratory tests. However, in all cases, the X-rays are done. They will always. But naturally, this MRI, although it is 100%, but it is not available at all places. But it's very useful because it shows the edema and the collection and in the bone and also an abscess much before that it is seen on any ultrasound or any of the plain X-ray. Similarly, a CT scan can be done, but this usually shows bony changes. This is more useful in the later stage. Means CT scan is more useful in cases which have been going for a long time. And just so you know that infection, if it's gone for over 6 weeks, is known as chronic osteomyelitis. We will just come to that. So in chronic osteomyelitis, the CT scan can actually help you because that can show you the areas of bone which are some new bone or the dead bone. Then, if you see a child and there is a suspected abscess there, or there is a subperiosteal abscess, and you can see, then the aspiration usually has to be done because you have to culture it first. Before you start the antibiotics, you should have a culture. It's best to have the aspiration and the blood cultures must all be done before we start, because it is if we give the antibiotics first and take the culture then later on, then you cannot get the right diagnosis. Then we cannot get the right organism. So we must have a pus specimen or the specimen, the blood culture, before we start them on the antibiotic. And then once we get the results, we can always then change them. If we are suspecting acute osteomyelitis, you take the cultures, but you must start antibiotics there, and then if a suspicion is strong on a broad spectrum, and then they always can be changed once you get the results, but you cannot wait for 48 hours. Large bore needle is often used for a subperiosteal abscess. The intravenous antibiotics then are started with broad spectrum cover till we get the culture results. Though. No surgery is normally needed if there is improvement within 48. If in 48 hours there is improvement, the temperature has gone down, the CRP has gone down, the child is well, he's not listless, he's come back to life again, then you might just hold on. But if there is, if you aspirate, there is pus, then if there is pus, or there's an abscess has been formed, or if they fail to respond to a conservative treatment within 48 hours, then we have to do that thing. You have to then open it and drain the abscess. Debridement means you have to debride all the dead tissue and the necrotic tissue there. And then you have to wash it down. Just as you know that when there's a pus coming out, now you have to drain the pus, you have to wash it up. And you have to wash it up with copious amount, with at least 6 to 10 liters of normal saline. Because just you know that the solution to pollution is dilution. So the normal saline or the washing solution will not kill the bacteria, it will make him diluted. So the solution to pollution is dilution. Karachi में आदमी रह रहा है अभी 100 yards में there are 2000 गाड़ी 2000 cars. So all that आप जब down जा रहे हैं तो all is changed. So what is there? Atmosphere becomes more pure because all that smoke and everything becomes diluted. So the solution to pollution is dilution. So drainage, so you have to drain, open and debride, excise all the dead tissue and then drill. If there's suspicion, then you have to drill the bone and you will see the pus, all that just coming out. And then you have to send again all those specimens for cultures and light mathematics. It's very important that all infections should be sent for culture because sometimes a tumor can present as a abscess. Similarly, in tumors, you must send a piece of culture. So all abscesses you must send for culture and for light microscopy as well. Now, if you have drained it well, then you have to leave a small drain in and the wound has to be closed. But if you think that it's still very dirty, then you can leave it open and then go and re-debride and wash again and then go back again within 48 hours. so that you can then close the wound. Now, what are the complications then? The complications of I mean, just as you know, as we have discussed, that this can happen from the head to the torso. So although it is only 1%, but you can develop osteomyelitis of the skull, osteomyelitis of the jaw, of the collarbone. And if it is there, then it can cause meningitis. If it's not adequately treated or well treated or half treated or delayed treated, not well treated, delayment of treated, inadequate treated, improperly treated, you have not given him the proper antibiotics and not for the proper duration. The duration has to be about 4 to 6 weeks time. You can give a intravenous for at least a week. But in some children, if their response is a bit slow or the organisms are microbial, it may give it up for a longer time. So intravenous can be from 7 to 10 days or 7 to 2 weeks. And then you have to continue for at least 4 to 6 weeks. Because you have to cure the infection. If it is half treated, the infection can smolder on and go on and can lead to chronic osteomyelitis, which becomes very difficult to treat. And then, as we discussed, in some areas, like the hip joint, when the metaphysis is coming, when the capsule is coming up to the metaphysis, a part of the metaphysis is intracapsular. Capsules can burst into the joint itself and cause septic arthritis. And that is a very important then to diagnose arthritis and treat in early stage. Because if you leave that too long, then that can cause destruction of the bone at very rapid rate. Of course, yes, you know, I mean, this is a metaphysis, and then there's apophysis, and between there's physis, and physis is a growth plate. Can disturb the growth. The growth can become lesser. Or if a part of the growth plate is damaged, then you can have a broken bone, deformities. So the growth disturbance can cause a stunted growth, or it can cause a deformed growth. Then you can have a pathological fracture strike. Limb length, because if there's a growth disturbance, then one limb can become shorter and leading to a limb length discrepancy. It can lead to abnormality of the gait and deviation. Now we come down to a very important, which is very common now, just as you know that I also lived and worked in Pakistan for nearly 10 or 11 or maybe 12 years. And you see this very common, chronic osteomyelitis. Because the acute osteomyelitis is not treated very well. A, the patients come very late. B, the patient mostly have a treatment down there though. And C, if the antibiotics are given, they might not be able to take it for a long time. The poverty is there. And the children, the nutrition is very poor. The host is not very good. And just as you know now that in children, the diabetes is so common. So with the diabetes, with the poor nutrition status, and with the poverty, the acute osteomyelitis is not being treated very well. And therefore, you will find, and you will get cases and see cases of chronic osteomyelitis. The biggest problem with chronic, it is very difficult to treat though. Right? The chronic is a result of inappropriate treatment of the acute infection. And then the trauma. How can trauma? But trauma is most commonly treated with what? I mean, you can treat it just as we discussed last time, that the fracture has to be reduced and maintained. For the maintenance of that reduction, you can either use a plaster or you can use a nail or a plate. So when you open the skin, among all the complications of internal fixation, the first complication is infection. So if there's a trauma, I mean, if you put a plate on or a nail on, that can get infected, and that is, if that can get, infected, it is within the bone though. It can cause osteomyelitis. If it needs for a longer time. So chronic osteomyelitis is any infection in the bone after 6 weeks, known as chronic of tissue then. Now it is very important to understand this, that what is happening there. So either there's inadequate treatment of the acute osteomyelitis, or there is a foreign implant like a nail or plate, or the fracture is open. Therefore, just as we had discussed, if the fracture is open, we have to treat it with early antibiotics in an open fracture, because the highest risk in open fracture is to develop osteomyelitis at a later. So the inflammatory process, which continues with time together with Staphylococcus aureus, Persistent infection in the bone will lead to, as we discussed, increased intermedullary pressure because of the intermediate accumulated pus, and this can lead to vascular thrombosis and lead to bone necrosis, though. And bone necrosis is known as sequestrum. But the bone, as you know, is a, although we think the bone is dead, though. Bone is not dead. Bone is very vitalized, dynamic structure, very highly vascularized, dynamic connective tissue, though. So when the bone, a part of the bone is dead, the vascularity, it will form a new bone, and the new bone formation is known as involucrum. All these are signs of osteomyelitis, the radiological signs, the telltale signs of osteomyelitis. There will be dead bone, there will be new bone. Involucrum is an attempt at formation of a new bone. And then there will be multiple openings. Once this involucrum has made multiple openings from the bone, from which pus is coming out, that's known as sinus formation. And those openings are known as cloacae. Then you can come down to here, and you can see that this is here formed, and then it ruptured and formed up here. You can see. So once this abscess has ruptured, periosteal abscess, and then you can, it goes on, and then it can forms a nidus, and part of this bone becomes dead bone. It becomes sequestrum, difficult to treat because the sequestrum, it becomes a bone of bacteria. What is a sequestrum? It's a dead bone, but it harbors all the bacteria. And for the antibiotics, vascularity difficult to reach, it's a dead bone. Therefore, the infection can harbor it for a longer time. And they're difficult to treat unless the sequestrum has been removed, though. And there are different types, as we know. There can be medullary, like if you pass the nail in, though. Superficial, if there's a chronic skin ulcer there, and that can develop. Localized, part of the bone has been dead, or it can be diffuse. And so in a medullary type, there's endosteal nidus. The focus of bone is inside the medulla, and soft tissue involvement is minimal. There's a sinus tract. Superficial can be on the surface of the bone, usually because of the overlying soft tissue defect. Localized, though localized sequester, the dead bone. Usually there's a sinus tract here, and then there can be diffuse. Now, it is very important to know that you have to understand the host as well. That what kind of host you are dealing with. Is it type A host who has got good immunity and delivery, or is it a B host who has got compromised, systemically compromised combined? But we usually have got C hosts, though, which have got their ability to fight infection is, very less. They are malnourished, type C host. This is just to say that most common is in an organism, again, in this is Staphylococcus aureus, but you can have Pseudomonas aeruginosa, Enterobacter, and more than 30%, of 1/3 of the cases, it will be polymicrobial, and hence becomes difficult to treat. Polymicrobial. More than one organism, so becomes difficult to treat. Now, what are the signs and symptoms? Signs, now, these are especially who are at a high risk. Those are at a high risk who are like elderly people, or who have got CERN3 host, malnourished, immunocompromised, or people who have got diabetes, chronic renal diseases. Then if they're immunosuppressed, if they're taking treatment, like if they're a patient who got rheumatoid arthritis and he's on methotrexate or on other things, or he had a kidney or a liver or transplant, then he can be on. If he is a diabetic, especially, diabetes, the key about diabetes, what the key is? Adequate sugar control. We were not very, very careful, because the key things about diabetic control are not only the tablets, but the food, the diet, and walking. If हमारे पास ऐसा walking culture और वो है नहीं भाई, कभी आम आ गए, ice cream, मिठाई आ गई, तो आते ही, we have to be just careful. So diabetes means we must keep it under a good control, better control of that. Then the IV drug abuse, but it is very common. Every week or 2 weeks, you get one के रात को भाई 2 बजे आ रहे हैं, भाई क्या abscess. You come in, the thigh is full of us, you drain 5 liters of pus from the whole thigh. Or the IV drug abuse here, they are, quite common. In chronic osteomyelitis, you can get relapses and then go up. Doctor, मैं एक साल सीख रहा. I was so good 1 year, and now again. So the bone pain can come on off. There will be remission and relapse. And in the treatment, you must have the deep culture. There will be a sinus tract, but you don't not take a culture from the sinus tract. It has to be taken from the deep down. The deep cultures in chronic osteomyelitis are very. Now, clinical, the acute we have already discussed. In the chronic, what will be there? There will be exacerbation of the fever. It can come on off. Signs will be irregular thickening of the bone, multiple sinuses, scar and muscle contractures. The pus. Discharge of bony spicules. What are these? The first of the dead bone and the pus. Deformities and decreased movement. As the pus becomes more, the muscles becomes contracted, the movements will become affected. And if it's involving the bone for a longer time, that makes the bone weak. Pathological. Pathological fracture means fracture of the bone where there's underlying problem. Can be a tumor, can be anything. Similarly, chronic infection in the bone can also make it weak. Though. Pathological fracture means fracture which is occurring in a bone which has got underlying pathology. And then you will see here again, here is chronic osteomyelitis. It is difficult to eradicate it completely. The sequestrum and all the sequestrum, dead bone. Systemic symptoms may subside, but one or more foci in the bone may contain purulent material, infected or a sequestrum. So the patient might get well, but the infection goes on. It might come back in 1 year time, 2 years time. There's a focus is there. Every time his immunity goes low, his diabetes becomes uncontrolled, he becomes ill, if then this can all flare up. It can go always, it goes up and down. What is this? This is a patient who had a fracture, and as we discussed last time, that when there is a fracture lower down, it's treated. So he has been treated well, but he has developed infection. So one of the complications of intense fixation is when you're putting a knife to the skin, there's always a risk of infection. Because knife to the skin means you're exposing the interior to the exterior. And therefore there will be a contamination. And if there's not adequate, it can lead to the infection. So there you are. This piece is all gone dead now. This is all dead. Because you can see that density here, and you can see that density here. So when the bone becomes avascular, it becomes dense. So on the X-ray, it becomes more white and dense. Because, and then here you are. You see here again, this is again here. You see, this is a tibia, and this is all this dead piece bone. So they have treated here, they have taken all this, the dead piece, you take it out and wash, irrigate, clear all these things, debridement, clear all these things, and then they have put here a stud graft. Stud graft is for a supporting thing. So here there's no involucrum 1 year after onset of the disease. So onset of the disease has happened. No involucrum means there's no attempt at formation of a new bone. Maybe the vascularity is not good. The host is not good. So to form a new bone, you have to have a good vascularity. You have to have a strong and a good host. If the host is poor, if the vascularity is poor, nutrition status is, poor, then. So 2 months now, and then sequestrectomy and a stud graft. Sequester means removing the dead bone. And stud graft means a graft they put here for supporting graft. So the first thing here is you don't treat them, and you see a chronic osteomyelitis, you don't, give them the antibiotic. Don't do that. Find the organism. Find the. So this is based on deep culture, not on empirical treatment. Treatment. And they have to be given IV antibiotics if they are ill. And if there's pus coming out, then you have to open and take deep cultures. Surgical debridement, there will be complete removal of the compromised bone and soft tissue. Not easy. Not easy though. Because when this happens, then you have to just reconstruct that. And that has to be removal of the hardware. And then that naturally, if you have removed all the compromised bone and soft tissue, you will need some bone grafting, some stud graft, some bone graft, and some soft tissue cover. Now, what are the complications? The complications are that there can be, now as it says, the first thing he has written is recurrence and recurrence and recurrence. It's not easy, but the best is to diagnose and treat the osteomyelitis in early stages and treat them in an adequate way and in a proper way. But chronic osteomyelitis is difficult to treat because there will always be a focus left in unless all the dead tissue has been removed, the soft tissue, which is not easy. It's not easy because it's very difficult to then replace all that bone and all the tissues, though it's not easy. And then naturally, it makes the bone weak and can lead to the pathological fractures. Growth disturbance, if it has occurred in a child which is still growing, it can cause amyloid disease. And in the sinus tract, you can always develop squamous cell carcinoma. So from the sinus tract, from where it is coming, you can always develop epidermoid carcinoma. Now we come to these children. Then in children, the arthritis or infection in these children. There's a long list, but we have to just concentrate on one thing though. This is a child. If a child has come who cannot move, who has got this infection, because you have to exclude the Coccus criteria. Although it's 7:29 now, so we'll just read one line, then we will come to a stop because your time is gone. I mean, it is 7:29 here. लेकिन आपके पास बज रहे होंगे ना 11:29. यहाँ तो भी बजे हैं सुबह के साथ. So it is here. This is asepsia. In children, all you have to know is that there's acute onset of pain and fever. The child appears sick, and the criteria is the fever is more than 38.5, 101.5. The child is unable to weight bear. X-rays in the initial stage they are always normal. The white cell count is more than 12,000. The ESR is more than 40, but now they say the CRP is important, but CRP is more than 30. If the CRP is more than 30, white cell count is more than 12,000, child cannot weight bear and walk, and the fever is more than 38.5. There's a strong suspicion, 99%, that there is likely to be a septic arthritis. Now it is 11:30. And Karam has to take one more talk as well. But just as you know that we are starting the sacred month of Zilhaj from tomorrow. So these are great 10 days to spend your time and make the connection with God. And then after 10 days, we have got the Eid. So may Allah accept all your qurbanis and may Allah guide us all to true path. Amen. And it is 11:30 now. So I wish you all the best and I wish you a very happy Eid to all of you. May Allah bless you all with mercy and health. Thank you very much. All the best. ओके सर 11:30 बज गए फिर ठीक है हाँ जी क्या मरीशा जी भाई हाँ ठीक है भाई हेलो हाँ हेलो क्या मरीशा सर
Sir, का mic off है sir.
जी जी हेलो यस हेलो जी आवाज आ रही है हाँ क्या मरीशा साहब जी हाँ भाई